Thank you very much. That gives me a fantastic opportunity to welcome you all for this very interactive ERA webinar session this afternoon on the 3rd of October. I hope that you have an equally nice day as we have here in London and the UK. It's my distinct pleasure to invite Professor Yen Ho to lecture on the importance of cardiac anatomy for electrophysiologists. Now, as you know, and probably the reason why you called in and got online today, Professor Ho is a worldwide authority on cardiac anatomy, and she has been lecturing on all the major courses, and any chance that you can personally possibly have to attend any of her lectures is always an eye-opener. You always learn something new, which is clinically relevant for any routine and clinical practice you might encounter. I still call Professor Ho up on a regular basis, invite her to come to the lab, and it's a distinct pleasure again to have her doing this lecture. I think there's no one better in Europe than Yen, that is a distinct and good friend of mine. So Yen, that gives me a fantastic chance, although we are on the same corridor, you are a little bit further away, to have you starting the lecture. We hope that we have a very interactive afternoon here. Please don't hesitate to put any questions in the little box on the right lower part on your screen. And again, I hope that you can participate very vividly on the multiple choice that are coming up a little bit during the presentation. So please keep on listening and voting and participating. Okay, Yen, please be so kind and start.
Thank you, Sabine, for your very kind invitation for me to start this webinar. I would like to welcome everybody to join in, especially towards the end, where you will be able to pose the questions that you want to ask. Sabine will also be moderating, obviously, and she's a dear colleague of mine, and we share many teaching expeditions together all over the place, so it's my great pleasure to have her on board. Very warm welcome to you all from a very, very hot, sunny afternoon in London. Now we move to important cardiac anatomy for the electrophysiologist. What I want to try and do is to present to you various aspects. Of course, within an hour or so, we cannot cover everything. So I would like to talk about the neighborhood, which I think is extremely important if you're working within and also just around the heart. Specifically, we will look at the phrenic nerves, the esophagus, and the vagus nerve. Then I would like to talk about the relationships of the cardiac chambers and valves. Of course, you have now very modern cardiac imaging techniques that allow you to see these very important spatial relationships. Then I'll move on to the structure of the cardiac chambers. So to begin with, I think it's important to know the heart as it sits in the chest, particularly the fact that the heart is encased by a fibrous pericardium. So I have drawn in a diagram the phrenic nerves, important for the right phrenic nerve to come down alongside the superior vena cava, or superior cable vein in the English version. So it comes down laterally along the side of the right atrium. And then on its course, you will see later on its passageway close to the right pulmonary veins. On the left side, of course, we also have the left vagus nerve coming down and entering also the left phrenic nerve. I'm sorry, we have the left vagus nerve coming down and forming the recurrent laryngeal nerve that curls underneath the aortic arch, and therefore in close relationship with the ductus arteriosus or its ligament, and therefore sandwiched between the bifurcation of the pulmonary arteries and the underside of the aortic arch. We, of course, have the counterpart to the right phrenic nerve, which is the left phrenic nerve, descending alongside and again over the fibrous pericardium. Over on this diagram here on the right-hand side, you will see the fibrous pericardium removed to show you the descending passages of the right and of the left phrenic nerves. So we then have these descents of the phrenic nerves inserting into the diaphragm. Now the proximity of the right phrenic nerve to the right pulmonary veins is very important in terms of ablation procedures that take place around the ostia of the pulmonary veins, particularly relating to the right superior pulmonary vein. So at this level, it is skirting very close to the ostium of the right superior pulmonary vein. You see on this panel the gross specimen with the levels of sectioning that you see on the right-hand side represented. So we made transverse cuts through the pulmonary veins and the superior cable vein. Here we have a section through the right superior pulmonary vein, therefore giving you a cross-section of the superior cable vein. You will notice this line here is the fibrous pericardium, and this little blob here, just sitting on top of that fibrous pericardium, is the right phrenic nerve. We have measured the distance on cadaver hearts, and we found the distance to be about 2.1 plus minus 0.4 of a millimeter for the right superior pulmonary vein. Regarding the right inferior pulmonary vein, that distance is a little bit further away, being 7.8 plus minus 1.2 millimeters. So therefore, the proximity of the right phrenic nerve is much closer to the superior pulmonary vein on the right side than to the inferior pulmonary vein. We also looked at the relationship of the left phrenic nerve in cadavers, trying to find out the relationship of the left phrenic nerve with regard to either the anterior descending coronary artery or its counterpart, the great cardiac vein, or with regard to the obtuse marginal artery or its vein, or indeed other locations. And this slide summarizes our findings from our publications, Sanchez-Quintana, and myself, and Jose Cabrera in 2009 and 2005. We found a lateral course in which it skirts over the vicinity of the obtuse margin of the heart, meaning it has a close relationship with the obtuse marginal artery and the obtuse marginal vein, which is important, of course, if you're going to be dropping down, leads into the obtuse marginal vein. There's a relationship with the anterior cardiac vein, or great cardiac vein, or anterior descending coronary artery in about 18%. In about 23% of these cadavers, the phrenic nerve took a more posterior inferior course, going over the left atrial appendage and curling around the more diaphragmatic aspect of the left ventricle. Another structure that is very important to take account of is the esophagus. The very posterior location of the left atrial chamber puts its posterior wall right up against the front of the esophagus, as you see in this cross-section. And this is a heart specimen cut through at the level of the superior pulmonary veins, whereas this is the same heart specimen cut through at the level of the right inferior pulmonary vein. So the position of that esophagus is not static. As you can see, it has a variable relationship either directly behind the posterior wall, or more to the right, or more to the left side. And similarly, you can also observe the relationship of the descending thoracic aorta at various distances from the posterior wall of the left atrium or from the ostium of the left pulmonary veins. By taking a longitudinal cut through the heart, we demonstrate for you on this panel here the relationship of that descent of the esophagus hugging the back of the posterior wall of the left atrium. We can also see the trachea ending here, and somewhere here would be the left bronchus, and here would be the roof of the left atrium, here being the posterior wall, and here being the inferior wall. In other words, the esophagus does not, well, the esophagus curves around the back wall of the left atrium, but does not make a straight descent. Indeed, it curls around a little bit towards the undersurface of the left atrium before descending through the diaphragm. This is a longitudinal histologic section taken through the left atrium and longitudinally through the esophagus. The green line here, stained up by Masson's trichrome stain, shows the fibrous tissue of the endocardium of the left atrium. And similarly, the green line here is the fibrous tissue of the fibrous pericardium. So we can see that this is the thickness of the posterior wall of the left atrium, which I make out to be maybe about 3.5 millimeters in thickness. Then there's a little gap, which is the pericardial space, and then the fibrous pericardium. And right behind the fibrous pericardium, we can see the branches of esophageal arteries, lymph node, fibrofatty tissues, and here already is the esophageal wall. And here, of course, the lumen of the esophagus. So we have a very close relationship between the posterior wall of the left atrium and not only the wall, the muscular wall of the esophagus, but also the arteries supplying the esophagus. Moving on further, we can take a transverse section this time through the heart and the lungs and the esophagus, and we find that the posterior wall of the left atrium is also related to some of the larger vagus branches that form the periesophageal plexus. So here we are, we see quite a large bundle of the periesophageal plexus just behind the fibrous pericardium, so in front of the esophagus. Again, a rather close relationship, because damage to this periesophageal plexus may result in delayed gastric motility.
And if I can jump in here.
Yes, of course.
I think it's a very, very important point that you're stressing, that the esophagus is really swiftly moving with every swallowing motion. Whenever you swallow, this esophagus can move all the way from the lateral veins to the septal veins, or the right veins and the left veins. So it is a very, very soft tissue. You see the fatty tissue between the aorta and the left atrium, and it can move quite a lot. In the barium swallow, you can nicely see that movement. And as you rightfully pointed out, patients that have gastric problems after, for example, an atrial fibrillation ablation, that's very likely that we exceeded with our attempt of making a transmural lesion and hit this vagal nerve right there. So it's a very close proximity.
Right. Any other comments, Sabine? Shall we move on to the next part?
Absolutely. I think we should move on. I think it's a very nice picture altogether to keep in mind when thinking about where the esophagus is and where the phrenic nerve is in relationship.
Sure. Now I would like to move to the next topic, which is to emphasize the spatial relationships of the chambers and the cardiac valves. And these are some still images taken from the endocast that I prepared many years ago. This is a sort of front view, if you like, but a little bit tilted to my mind, to show you the right heart chambers are not strictly right, nor the left heart chamber strictly left. We can see the right atrium, right ventricle, pulmonary trunk here, but in between the right ventricular inflow tract and the outflow tract, we see the aortic root. We see very little of the left ventricle from the front, we see a little bit of the left atrium, which is the left atrial appendage. Instead, you see more of the left atrium when you look at the heart from the back, because it is the most posteriorly situated of all the cardiac chambers. Also note the relationship between the pulmonary arteries, the right pulmonary artery and the left pulmonary artery, to the top of the left atrial chamber. The right superior and right inferior pulmonary veins pass to the back of the right atrium to get to the lungs. Specifically, the right superior pulmonary vein passes rightward between the junction of the right superior cable vein and the right atrium. However, when you look up the heart, for example, from the left anterior oblique kind of projection, so we're looking up from the apex, we can appreciate how the right ventricle wraps around the left ventricle. So the left ventricle appears more or less circular in fashion, with the coronary sinus and the great cardiac vein curling around its perimeter, marking for you the approximate site of that mitral annulus. Some more pictures this time. Again, anterior-posterior view versus right lateral and left lateral views to emphasize for you that the left part of the heart, or left heart, left atrium, left ventricle, can be visualized better by looking from the left side of the heart. You see practically nothing of the left heart when you're looking from the right side of the patient. And very important to realize or appreciate that the ventricular outflow tracts, both the right and the left, are not parallel in the normally structured heart. In other words, the right ventricular outflow tract passes cath-led, if you trace from apex to the pulmonary valve, that passes cath-led and over the left ventricular outflow tract, which is underneath it. So the left ventricular outflow tract, when traced from apex to the ascending aorta, goes leftwards and rightwards and headwards. So we have a very important crossover relationship between right and left ventricular outflow tracts.
Can I jump in again and
yes, of course.
Maybe add that with this very nice picture in the middle, that you can, if you come back from your echo projections, you can very nicely see that the aorta is a very central structure in the heart. You can see that nicely on all three projections. And in fact, that the right ventricular outflow tract, which becomes interesting when you have to ablate, let's say, an ectopic ventricular arrhythmia from this area, crosses over that aorta, and it gives you very nice guidance. If you have, for example, a catheter that marks the aorta, and I'm sure Jen is going to point that out a little bit later, how to find these important structures like the aorta in the middle of the X-ray picture, if you want so, during a case. So aorta is a very important marker to get oriented, and the second, I think, very important marker to get oriented in a heart is the AV plane, which very nicely can be seen in the lateral projections. And you see on the left picture, you can see nicely that the right atrium and the right ventricle are nicely separated. And on the right picture, on the left lateral projection, you can see that the coronary sinus is such a nice marker of that same level. So keep that in mind as we progress to the later parts of the talk. These are kind of two major structures that allow you to see essentially the heart if you enter the cath lab and try to get oriented.
Thank you, Sabine. These are very relevant remarks, particularly the very central location of the aortic root being related to both the pulmonary outflow tract, the left atrium, and the right atrium. And we'll look at these in a bit more detail shortly. But note on this picture also the different levels of the pulmonary valve versus the aortic valve and the angulation that these two valves take. So they're not in parallel and they're not at the same level at all. And here we show you the tricuspid valve plane, and the mitral valve plane is just behind there. So next we move to the various chambers and just touch briefly on the sinus node an atrioventricular node. So for us as anatomists and morphologists, each atrial chamber has these components: an atrial appendage, the venous component receiving either the cable veins and coronary sinus or the pulmonary veins, the vestibule, which is the area of the atrial chamber just proximal to either the mitral valve or the tricuspid valve. And then, of course, the septum, which is shared by both atrial chambers. But first, the sinus node. And these two dissections just depict for you in this panel here, more or less your right lateral kind of projection, showing the location of the sinus node at the junction between superior cable vein and right atrial appendage. And by the way, this whole structure is the right atrial appendage here, not just this part of the atrium. So the sinus node is located anteriorly and laterally relative to that junction between the cable vein and the appendage. In this dissection, the heart is rotated around, so you're looking at it more or less from the anterior aspect. And we again show you that sinus node position. And you will notice that I've put in dotted line the borders of the sinus node, but actually the nodal borders are not discrete. The nodal cells, specialized nodal cells, extend to various extents into the working atrial myocardium, as depicted by these little prongs of dotted lines. Incidentally, in this particular heart, there was an extension of atrial tissues over the outside of the superior cable vein to quite some distance, about 2 centimeters in all. The atrioventricular node, of course, is located in an area of the right atrium, which is described as a triangle of Koch. In this dissection, we have opened up the heart as if you're looking at it in a right anterior oblique kind of view. But to do that, I have split away the free wall of the right atrium, which is primarily the free wall of the right atrial appendage, so that you see the crista terminalis and the pectinate muscle. So I flipped that backwards to show you the junction between the superior cable vein and the right atrium. And I've put it in dotted line, the location of the sinus node. The atrioventricular node is encased or is located at the apex of the nodal triangle, which is bordered anteriorly by the insertion of the septal leaflet of the tricuspid valve or the annulus of the tricuspid valve. The posterior border of triangle Koch is marked by the tendon of Togaro, which is located within the musculature of the eustachian ridge. At the apex of the triangle Koch is the central fibrous body, of which the membranous septum is an integral part. The inferior border of the nodal triangle is marked by the orifice of coronary sinus and the vestibular portion of the right atrium. So here I've put in the location of the atrioventricular node. I've drawn it more or less like a frog with two legs because it has a nodal body and it has inferior extensions which have been implicated in the slow pathway of AVNRT. And I've also put in dotted line here the common or typical flutter isthmus or cable tricuspid isthmus that is ablated in this region. So from the annulus of tricuspid valve passing through to the eustachian valve guarding the inferior cable vein. Usually in about 10% of individuals there will be a dip of the sub-eustachian sinus or a pouch in this position. The wall composition of the flutter isthmus is usually smooth vestibule anteriorly, then a whole range of muscle bundles and fibrous tissue in the middle, and then more fibrous tissue posteriorly. Over here, the smooth vestibule between the orifice of the coronary sinus and the annulus of the tricuspid valve is usually described as the septal isthmus. And these are two diagrams just to give you some flavor of the variability in the so-called cable tricuspid or typical flutter isthmus, which is this line here. Again, the AV node put in position. And on transillumination of one of these hearts, you can see the various muscle bundles and the thin areas made of more fibrous tissue than muscular tissue.
Can I come and comment once more? If you
Yes, of course.
Maybe go one slide back.
Mm-hmm.
I think it was a beautiful depiction of how close, once you would choose to make a very septal line very close to the coronary sinus catheter, that you actually come very close to that inferior input, that one of those prongs that you pointed out here with where you put the AV node. And although the line is shorter, if you connect the tricuspid annulus to the coronary sinus and then to the IVC, you risk coming quite close to the AV node, and that is really one of the inherent complications if you do a very septal line. So although the other line, where you have your dotted line, is much longer, it's much safer from an AV conduction, AV nodal conduction point of view. And as you see, you can have a very thick muscle bundle or very thin areas in that, along that dotted line. So the key really is to reach all the way to the annulus and then follow all the way down to the IVC and stay away from risking damaging the AV node.
Okay, so now we want to know what can be the potential obstacles for accessing the coronary sinus. And here's a dissection viewed from above. So we have the tricuspid valve here, so right atrium, and I've drawn the blue line into the coronary sinus and the continuation into the great cardiac vein. In fact, this channel then passes underneath the left atrial appendage. And I've used the same image and flipped it over the other side so you can kind of get an impression of the LAO kind of view, with the aortic valve in the middle and the curvature of that coronary sinus great cardiac vein course. Now, the first valve that you will encounter as you're coming through from the inferior root via the inferior cable vein into the right atrium will be this structure here, which is the eustachian valve. So this is quite a regular looking kind of eustachian valve, a bit triangular in shape, not too high, not too short, not too low down. But occasionally you may come across one of these, which is known as a Chiari network formed by the remnants of the right-sided venous valve that forms itself into a kind of fishnet configuration, sometimes also involving the Thurbezian valve over the coronary sinus.
Jan, can I ask, would we actually feel that if we would have that kind of
I think so. If you come through here and you get entangled within this Chiari network, you may find it a little bit more difficult to kind of move your catheter around once you get into the right atrial chamber.
Mm-hmm.
Oops. What about the Thurbezian valve? Well, it takes various shapes and forms. Sometimes you have no Thurbezian valve, unguarded, which is quite rare. But more often you will have a membrane with varying degrees of fenestration, or you may have strands. And very rarely you come across one of these situations where you have a large flap forming that Thurbezian valve. The orifice is tucked in behind that flap. So you may then find it quite challenging to enter this particular variation of Thurbezian valve anatomy. And I think we now come up to a question time. Can we move over to the question, please?
Okay, I hope that you all see the questions on the right corner of your screen. Jan, you want to read them out? And
yes, the question is, which structure of the left is not in the neighborhood of the left atrium? So we have A, esophagus, B, left phrenic nerve, C, descending thoracic aorta, D, right pulmonary artery, E, right coronary artery, and F, coronary sinus. So please select one.
Okay, we're going to have a couple of seconds to have everyone voting. And in the meantime, I might comment a little bit on this slide that you're showing us on the left side. So we wait for the result, which is going to be displayed to us, I hope, so we can have a chat about this. Now, with these guarding valves in front of the coronary sinus, it's sometimes quite difficult to position the catheter in the coronary sinus. So there are various techniques in finding out that you're already there or trying to get the catheter kind of jumping a little bit further. Now, the guarding valve is one problem, but the second problem, I think, is that sometimes the catheter gets entrapped in the first branch in the middle cardiac vein, and you cannot really easily advance the catheter. Is there any trick that you could tell us? Is that very simple or very often that right after the membrane or right after the entrance of the coronary sinus that there is a branching vein that makes advancement of the catheter difficult?
Once you're inside the coronary sinus, you may encounter a little bit of flat valve that might be there, or you may have, as you say, a branching vein. These are possibilities.
Yeah. I think
we have the results now on the questions.
Yeah.
This is quite interesting. I think majority got the answer right, which is E, the right coronary artery. In fact, if you look down the list, esophagus, everybody got that right. Somebody said left phrenic nerve. In fact, that left phrenic nerve can pass over the left atrial appendage. Descending thoracic aorta may be to varying extents behind the left atrium. The right pulmonary artery actually can sit on top of the left atrium. The coronary sinus, I didn't stress it, was actually passing along the inferior wall of the left atrium. So we come back now to the talk. And we need to know how to get to the left atrium. I think this is very important. This is a very important image to appreciate the location of the atrial septum. Basically, we're looking down from the right shoulder, if you like, towards the ventricle. So we've taken away most of the walls of the atrial chambers. We can see immediately the very central location of that aortic valve, with the left and the right coronary arteries taking off from the two aortic sinuses that are very close to the pulmonary outflow tract. The non-coronary aortic sinus lies just in front of the plane of the atrial septum and is related to both the left atrium as well as the right atrium. So there is a part of that right atrial chamber anteriorly which is related to the aortic sinus here, the bulging aortic sinus, and this is termed the aortic mound, which is not truly of the atrial septum. In other words, going through here will take you into the transverse pericardial sinus and may even enter the aortic root, but not across to the left atrium.
You know, actually, I'm missing your nice little red ball to point out which area you exactly mean. Is that?
I'm sorry. I think I need to click on the laser again.
Yeah,
right.
There,
so here is the aortic root, and here is the plane of the atrial septum, and you can see it pointing to the non-coronary aortic sinus. And the bulge here, caused by the aortic root, is termed the aortic mound, which is not a true septal structure. It will take you outside of the heart if you pass through here and not into the left atrium.
Right. I think it's a very nice picture again, and shows the importance of knowing where the aorta is if you try to get over to the left side. And I think you pointed that out very nicely, the neighborhood between the aorta and the His bundle recording site, the compact AV node. And that would be a catheter showing you a His potential would nicely mark where the aorta is. And then you stay away of being so far anterior. Can't yet see that in this projection, but I'm sure you're going to show a more lateral
Absolutely.
view.
I think I'm trying to put the red dot here in the position of the His bundle, so you can see how closely related it is to the aortic root. Okay.
Mm-hmm.
The precise location of the atrial septum varies, but generally it is not running in an anterior and posterior direction, but rather more obliquely. So this is an image taken from one of our recent books, showing you the right atrium, left atrium, and the oblique orientation of the atrial septum.
Let me make another comment here and say that if you have a 3D image of your patient, you can easily, in a three-dimensional fashion, orient yourself. It's nearly as nice as seeing the specimens of Professor Ho or any other anatomist that you can possibly meet. Now, people sometimes ask, so how many degrees in LAO are you looking at? And it really depends on the axis of the heart. You see here probably the axis about 40, 45 degrees. And you could nicely individualize that angulation by having, going a little bit further around, let's say, to a 50 or 60 degree LAO, or in fact going a little bit less if the heart is more sagittal in the chest. Now, coming back to that His catheter or an apex catheter that crosses the tricuspid valve, which will lean on the septal wall from the right ventricular side, that's a perfect marker. If you have that pointing towards you, then you have the right axis, the individual axis of the patient in the cath lab.
Okay. We also have various conditions which are listed here that can change the orientation of the atrial septum. So this is not an exhaustive list. So. And moving on, so anatomically speaking, the perfect spot for crossing to the left atrium from the right atrium is through the floor of the fossa ovale, which is this thin, flat valve or membrane that guards the fetal or embryonic fossa ovale. The limbus around the fossa ovale is made by the septum secundum, and you can see the infolding that makes that septum secundum. So we have the muscle of the right atrium folding upon itself, and over here with the asterisk is epicardial fat. So in other words, if you're straying too superiorly, here's the entrance of the superior vena cava. If you're a bit too superior, you actually cross outside of the septal area to get into the left atrium. And by the way, I think this picture shows rather nicely that straight ahead of you from the septum are the left pulmonary veins and the left atrial appendage over here. But to get to the right pulmonary veins, they are lying more or less in the plane of the atrial septum.
Can I comment once more? If you puncture where the error is, then you actually have a good range with your catheter, and that area is quite floppy, so it will allow your sheath on your catheter to turn very easily. If you puncture more through that limbus where the asterisk is, where the red dot is now, you still enter in the left atrium, and you're still going to measure, for example, left atrial pressure, but the sheath will not be so easy to be rotated. And in fact, you exit the right atrium and then you re-enter through this interventricular fold here. And if you're very unlucky and the patient has not as much fat as this patient has, then there might be a chance that you actually enter the pericardial space, which in the long run, especially when you pull your sheath out, is going to cause a problem and possibly cause tamponade. So it's much easier mechanically to then rotate the sheath if you go through the fossa, through the membranous part, and not through the thicker part, although you end up in the right area afterwards.
So we look at it in more detail. We see this configuration of the true septum, which is the thin part, and the limbus, which is an infolding of the atrial wall. And this can indeed be imaged on real-time three-dimensional echo, showing epicardial fat in the thin area of the fossa ovale. And using the same technique, we can also visualize the variability in morphology of that fossa ovale. You may have something with very nice, prominent rims, a small fossa ovale, or you may have one which is very flat. There's no real distinction between limbus and the floor of the fossa ovale. The location of the fossa ovale valve can also vary from individual to individual, not always centrally positioned. And particularly if you have a very posteriorly situated fossa ovale, the risk of going posteriorly can take you outside of the heart into the pericardial space as well. And just to complete the atrial septum, just some more images showing you the thickness of that limbus can vary. In this case, you may have what is termed lipometer septal hypertrophy, which means that the infolding is filled with a lot of fat, maybe 1 centimeter, 2 centimeters thick. And as Sabine mentioned earlier, if you were to cross the septum through this area, it makes the catheter much less maneuverable compared to if you're crossing through this very thin area. And of course, you need to be aware that there may be other previous procedures through the septum, devices, surgical patches, and so forth, which may make crossing the septum more challenging than usual. So to summarize, the atrial septum may be small without clear margins, maybe large with clear margins, or maybe even aneurysmal. And oftentimes when you have an aneurysmal septal aspect, that is very stretchy and can take you further into the left atrial chamber than you anticipate. And just to summarize the picture again, very important relationship of the aortic root to the septum. And I think we'll stop the presentation here, but I have one more question to pose to you. Can we go to the question number 2, please? Which aortic sinus is closest to the atrial septum? The right coronary aortic sinus, A, B, the non-coronary sinus, C, the left coronary sinus, or D, none of the above? You actually have the picture in front of you, so I expect 100% correct answer.
So again, in the time that people vote, let me try to explain. There were a couple of questions from the audience. And one of the questions was, what are the radiographic markers to find the septum? And I think it's worth pointing out that there's not always these first jump in the right atrium and then the second jump in the fossa, because sometimes the limbus is not as pronounced as you've shown it. And this picture actually shows you very nicely that sometimes can be very shallow, and sometimes you have a beautiful second jump, and then you know exactly. Now, as you know, my personal practice is that I mark where the aorta is with my His catheter, and I mark where the coronary sinus is with my CS catheter. And I'm not sure if you can help me to point that out, but on the middle picture of what we see here, you could see that you have a shadow of the right atrial posterior wall, which very nicely imposes on X-ray as well, and you would see where the aorta is. I don't know if you could move your red ball because my mouse is not checked.
I can't because we're on the polling on the.
Oh yeah, so maybe we go back to the answers.
So can we go to the answers first then?
And then we can go from there.
Okay.
Yeah.
Well, I'm rather surprised actually because you do have the picture in front of you, and you should all get the correct answer, which is B, the non-coronary aortic sinus, because here. You find that the right and the left coronary sinuses are more anteriorly situated. Okay, so we move back to the present. Can we move back to the presentation? Okay, I've got my red ball back. Shall we let's go back. I think this is so important that I need to go back to this particular picture. Here we are. Here's the atrial septum. Here's the non-coronary aortic sinus just facing atrial septum. The left and the right coronary aortic sinuses are not in the vicinity of the atrial septum, but instead in the vicinity of the right pulmonary outflow tract and the pulmonary valve. Sabine, do you
This is
think...
a very nice projection. So if you would think that you would sit just the opposite way and sitting in the ventricles and looking backwards, it's very nice if you have, as I said, the catheter, the his sitting here, marking where that non-coronary to right coronary cusp is. And then if you go forward to the next slide, I think that was a nice depiction. One more slide.
Oops.
Oops. Yeah.
This one?
This one is probably not so bad. So here you could see where the coronary sinus is. It would be marked by your catheter. Most people do have a CS catheter in anyway for the atrial fibrillation ablation itself. And by having these two borders, you have the CS that gives you kind of an anterior border, and you would have the shadow in REO. You would have the shadow of the right atrium very nicely here. You should aim to something in the middle third in between. You should not go too high. Just go for the next slide. One more. Here, this may be a good place. So here, this is like an REO projection. Here's the aorta. Here's the posterior wall, and you would see that on X-ray as well. This is a beautiful 3D reconstruction from echo. And then you could pull back your needle, and you would possibly jump if you're in the picture in the case like where the red dot is at the moment. And then you could make sure, if you watch the REO projection, REO 30 should do, that you're not too posterior and you're not too anterior, you're not getting too close to your his catheter. So if you're staying in the middle third, you should be aiming exactly at the fossa. That gives you most of the time a good projection. And then what I do personally is I puncture an LAO, so I can see when I actually tend the fossa, like invisibly, but I can see when I push the needle forward how I pass behind the his catheter, and I'm within the shadow and above the CS catheter, so that I'm being in the right area. And I do puncture with intracardiac pressure, so I see the pressure rise of the left atrium. If I would be too far anterior, if I would hit the aorta, I would see a very high pressure rise, and then I would see systemic pressure, and I would just pull my needle back and aim a little bit more posterior. But that is a very nice projection, REO, to hit that fossa directly. So I hope that we have answered Dr. Hussein's question, and please keep on texting these questions, and we can interrupt and show specific parts of the slides again.
Sabine, can I ask you how many questions have you received? Because we are getting close to the end of the session.
Yeah, there was another question earlier, and I saw it unfortunately a little bit too late, where someone asked a trick on how to cannulate in the coronary sinus if it's difficult. And the suggestion was to come from the crista terminalis like in a big loop and then come in. Now, I can quickly tell you my tricks. The trick is initially to come from the tricuspid annulus and come from more like a his position and deflect the catheter down, because most of the valves, the Sabesian valves that guard this coronary sinus ostium, are kind of opening to the top. And that's actually quite a nice way of sliding with a big V first, big ventricular signal, and then turning the catheter clockwise and deflecting it until you have a very big atrial signal. And then you're in the ostium, and then you can carefully advance the coronary sinus catheter. Or, if it's really, really difficult, I come with a superior axis coming from above. But as described here by the colleague, I think it's Dr. de Carrera, you can come with a big loop, but I find that very difficult to negotiate in the coronary sinus, because then you have a lot of action from the ventricular contraction, because the catheter lies on the isthmus, and you have some movement in that direction that kind of kicks you a little bit away from the ostium.
Okay, Sabine. Shall we? Do you want me to
coming up? But I think we should just go on. There was a question of if you always need to put a CS catheter if you puncture the left atrium. You certainly don't have to. There's no rule that you have to, but it's such a nice marker for the anatomy because it nicely shows you, again, on this picture as we see it now, the coronary sinus in the REO plane is marking very nicely the AV plane. And you don't have to do it, but it's actually making things easy. And actually, it's very nice for, let's say, left-sided pathways to see where the pathway is bracketing. Or if you do pulmonary vein isolations, you can pace from the coronary sinus and see if you have already isolated, and it makes the differentiation to the pulmonary venous potential much easier if you have a CS catheter. But there is no written rule that you have to have one.
Okay. What do you want me to do? We're coming up nearly to time. We've got about 8 minutes maximum. Shall we stop at the atrial chambers or what? Sabine?
Well, I have a small indication here that I should let you talk and should not interrupt too much. So I think we just go and see how far we get.
Okay. Right. I'm going to talk a little bit about interatrial connections, the left atrium and the pulmonary veins. So the atrial chambers are not connected only at the septal level, but we also have other muscle structures that can connect right and left atrial chambers. And of course, the most well-known one is Bachmann's bundle, crossing the front of the atrial chambers. But there are also various muscle strands, sometimes some thinner, more slender, some bigger and broader, connecting, for example, the right superior pulmonary vein to the back of the superior cable vein, or between the left atrium to the intercable area of the right atrium, or between the coronary sinus and the left atrial musculature. So these are numbers of percentages were taken from a series of heart specimens we dissected out. In talking of the left atrium, of course, a lot of attention has been focused on the pulmonary veins, particularly the pulmonary venous sleeves. In fact, these are not new inventions. They have been described very, very long time ago, more than 100 years ago, in fact, in the description by Keith and Flack when they made the discovery of the sinus node. They included a diagram in which the pulmonary venous muscle sleeves were drawn in, also the superior cable vein muscle sleeve drawn in, but no inferior cable vein muscle sleeve. But in this longitudinal section, you can see that the muscle sleeves are extensions of left atrial myocardium going over the outside of the pulmonary venous walls, extending towards the lung hilum. So they are thicker near to the area that we've marked as veno-atrial junction, but of course anatomically no discrete borders between atrium and vein. The wall thickness of the muscle sleeve fades out as you go towards the lung pulmonary segments, and also you find interruptions in the muscle sleeve, and also clusters of autonomic nerve branches, and usually in the region of the veno-atrial junction. Staying with the left atrium for the moment, there are particularly with regard to the thickness of the left atrial wall, and this is just a series of consecutive autopsies in which there were majority with no AF and fewer numbers with atrial fibrillation recorded in the history. 3 spots were made, 3 spots of measurements between the superior pulmonary veins and between inferior pulmonary veins, and a central location. The only significant difference were found in the central location and also in the inferior location between the pulmonary veins, between those without atrial fibrillation and those with history of atrial fibrillation. And finally, for the left atrium, there's an area of interest, particularly relevant to encircling the left pulmonary venous ostia. There is a ridge, so-called ridge, that separates the left superior pulmonary vein from the orifice of the left superior pulmonary vein from the left atrial appendage. In fact, this ridge, although it appears as a ridge on the endocardial surface, is actually an infolding of that left atrial wall. And in the vicinity of this left lateral ridge, as it were, you may find pits and dens in the atrial wall leading up to the os of the left atrial appendage. The left atrial appendage itself varies in morphology, generally finger-like in shape, as you see here. Sometimes that finger can point forwards over the pulmonary trunk or over the left coronary main stem. Sometimes it can point backwards. Sometimes it is shorter, sometimes longer, and so on and so forth. But what is important in terms of closing the ostium of the left atrial appendage is that just underneath the neck of the left atrial appendage, you will find the circumflex artery, and also usually the great cardiac vein comes up here and curves underneath the location of the left atrial appendage.
Can I
so Sabine, I think I will stop here for the lecture.
No, actually, I got instructions that we could continue if you're happy. But I had a short question. With all these little holes that you see here on the left atrial appendage on the right picture, when we do an isthmus line connecting the left inferior pulmonary vein to the mitral annulus, sometimes I have the impression sometimes it really is easy, exactly. And sometimes I spend hours and I finally have to ablate in the coronary sinus. So I personally try to avoid that line as much as I can because I know it's a difficult one. So, but with that very thin area here, is that an area that we should be able to ablate easily? But then on the opposite side, on the outside, we would see the coronary sinus here, right? And as you pointed out, also the circumflex artery is very, very close, isn't it?
Correct. So these may trick you. You suddenly find yourself dropping in, and really the left atrial wall where it's transfiltrated is incredibly thin, paper thin, I would say.
Okay, now we have a very important decision to make, and I'm very happy to go either way, and I hope that Professor Ho is equally flexible. We are coming up to the end of the transmission time. However, we've only covered so far the atrial anatomy. So one option would be to continue. And the second option would be to invite everyone back for a second session on the ventricular anatomy on a second date. So I'm not sure how we poll this question, but if we could instantly poll, I would need to have some indication from the organizers if we should continue or if we are actually satellite-wise cut out.
I think we need to hear from Nadine.
It's up to you to decide. If you want to go up to the end of your presentation, I'm sure everybody will be happy. Otherwise, of course, we can schedule another webinar on a later date, and I will, of course, keep everybody updated. So it's up to you, Professor Ho, but please go ahead if you want, or we can schedule another webinar on a later date.
I think it's going to take me at least another half an hour to get to the end of the presentation. So I think it might be wiser to schedule another date, and then I can talk a bit more about the ventricles, if that's all right with everybody.
Perfect. I think that is, we need to respect the person who's doing the whole talking. That gives me, I think, probably the word to finish the session, and first of all to thank Professor Ho to share these fantastic pictures with us, and to see if we can, and I'm going to turn my camera on to give that maybe final speech here. I hope that you can see me. I think we had a great opportunity to review the anatomy of the atrial chambers, and I think some very insightful pictures were demonstrated here, and even the last picture that you still see on your screen, I hope that you take that back with you in the cath lab when you do the next ablation around the pulmonary veins, especially that ridge where the asterisk is pointing to. Very difficult area to do. So I hope that you enjoyed this session. We hope that you come back for the ventricular part of this. it was probably a little bit too courageous to review the whole cardiac anatomy of all 4 chambers in an hour. That is possibly a too large area to cover altogether. I think I speak for all of you that I enjoyed it greatly. I hope you enjoyed it greatly. If you enjoyed it so much that you would want to tell your colleagues to dial in the next time to